Good morning, everybody. Dr. Todd at Move Now, and I wanted to talk about a phone call I had the other day with one of our members of Move Now University. He was asking about how we deal with an acute patient and the exercise protocols in the belt system, so I just wanted to cover it, and I figured I would make it general enough so that even if you are a non-member watching this and you're just been following our stuff and you're wondering how this works, this will be helpful and applicable for you. So if you want to see inside of our program, if you haven't checked it out yet, we have a demo that we did. I actually re-recorded it because we had our 12-week implementation process all completely updated as of about a week and a half ago. It's pretty fresh off the press. So if you go to demo.movenowu.com, you can see a 30-minute demo that I recorded of inside the doctor portal, the staff training portal, everything. You can see all the different sections and lessons and tracks inside there. So now talking about how do you take an acute patient through exercise? Because this was a question I was chatting with a doctor the other day who's in the process of going through the 12-week implementation, and he was just saying, okay, so if someone comes in and they're super acute, like they hurt their low back, that person can't be foam rolling and they can't be going through activation exercises and whatnot. And I said, yeah, you're right, they can't. So here's pretty much how that works. A couple things I want to cover. One is you don't ever want to have someone do an exercise that causes pain, because the whole component of corrective exercise and even strengthening exercise is that you are trying to make the person more functional, and if they have any pain when they're exercising, they're going to move in a abnormal pattern to try to avoid pain. That's why a lot of people get dysfunctional to begin with, is because they had pain, they still need to get from point A to point B, and they try to reorganize their movements to accomplish that task, and they end up maybe using muscles that are more of stabilizers now as prime movers. The prime movers shut down, and now you start to have a whole other slew of like this snowball effect, or like a domino effect of other dysfunction and then other sources of pain that are created as a result. So we do not exercise someone when they have pain, and we do not put them through mobility techniques that cause pain. But now it's also very important to be able to define what pain is, because you have some patients that are hypersensitive, or they think anything that's uncomfortable is pain. And the verbiage that we usually use is that exercises or mobility drills can be challenging, but they should not be painful. So what's painful? Painful is like sharp stabbing, burning, something where you wouldn't be able to hang out there for more than a couple of seconds. Doesn't mean every exercise needs to feel good. It can absolutely be challenging. It's a new movement someone's going through, but it's a little bit subjective, but it is something that needs to be talked about and defined with your patients. Now, let's talk about like an acute low back pain patient. When that patient comes in, we still take them through the same process of analysis, of educating them what's going on, and then trying to decide what route they want to go with care. Meaning, we have a day 1 through 5 process, really. Okay, where day 1, we do a consultation exam, and the exam consists of going through orthopedic, neurological, hands-on chiropractic exam, visual and digital postural assessment, and then if warranted, in most cases it is, we take x-rays of the spine. Then all that stuff's analyzed. If the person is not acute, then they're usually getting seen and adjusted the following day after everything's analyzed. If they are acute, then we're going back and we're working on them that same day. We're not able to explain a whole ton on their x-rays yet because we haven't fully analyzed them yet, but we've looked at them enough to at least make a judgment call to give them their first adjustment. We usually work on one segment. Okay, so if it's an acute low back and it's a bad fifth lumbar, we'll work on L5. But that's it. We're not jumping around and we're working on all these different areas of the spine without fully having everything interpreted and analyzed yet. Then their second visit, we then are explaining their x-rays to them. We call that the BROF, the brief report of findings. prior to the broth, they're watching a video on x-ray analysis, so they have a foundation of knowledge so they can understand what we're going to be covering, what to expect, how it works. And we then explain their x-rays to them. And we give them either their first or second adjustment, depending if they were adjusted on day one. And then this is where there's a little bit of variability. If they are acute, we're not going to do a movement assessment with them if they're so acute that everything's going to fail and show that there's a problem. We'll make a note that the reason we didn't do a movement assessment was because they were so acute, and then we will plan to do a movement assessment at a very soon later date, hopefully within the next week or two, when they're out of their acute crisis. We're doing things to, of course, get them out of the acute crisis, primarily adjusting. But there's some other things that we do quite often as well. We'll send them to the exercise department and go through some manual therapy protocols. We'll do instrument-assisted soft tissue mobilization. We'll do taping. Those are all very effective things to reduce pain, on top of course, fixing the cause of the problem, which is a lot of times a segmental issue that we're addressing with specific chiropractic adjusting. So now here's the whole point that I'm getting to here, is that even if they're acute, we're still following our process of taking them through and educating them properly on how these things work. And on day 2, that's where we talk to them about, how do you want us to take care of you? Do you want just short-term pain relief and then that's it, and not address any of the structural or functional issues that may be there, because maybe the patient's too acute to assess all their functional issues, like with a functional movement assessment? So we haven't really gathered that data yet, but we're explaining that that's normally how we do our full workup. So do you want to just get temporary pain relief, short-term pain relief, and not address the structural issues and the functional issues that may be there? Or do you want us to get you out of the acute crisis, but then start to address the things that we already know are underlying problems, then go through, do a functional movement assessment, and then map out some protocols to teach you how to start fixing this and teach you what you need to be doing outside of the clinic, so that you can have a lifetime of certainty and stability, and eventually start building some strength, so that you don't have to worry about this forever. Is that something that you like? Either option A or option B. They're two very different options. And then you shut up and you let them tell you what they want. And they say, yeah, I want to get it fixed. I want to do this. Okay, why do you want to get it fixed? Why is right now a good time and before it wasn't? Well, because I'm just sick of this and I'm ready to do something. I understand this is going to keep coming back over and over again. Okay, gotcha. All right. So then at that point, we're then working on them on that visit, and then they come back on day 3. Day 3 is where we're going to map out a game plan based on the knowledge that we know thus far. But we're going to map out a game plan for them to take them through our 12-week transformation. It takes 12 weeks before you have any sort of huge, measurable objective change. I'm not saying you can't get someone feeling better or see some objective things change in 2, 3, 6 visits, but I'm saying to really rewire how this person is operating, and especially if you're trying to make structural changes, like the person's got a thoracic hyperkyphosis and you're changing that with curve correction, so spine remodeling traction, postural corrective exercise, home care, so functional movement exercises to activate the associated muscles that are correlated with certain postural issues. Like a thoracic hyperkyphosis usually has a disengaged or weak posterior chain that needs to be activated. To be able to see good objective measurable changes, it takes 12 weeks in most moderate to severe adults. That's just what we've seen clinically over the hundreds and hundreds of patients that we've taken through these protocols. So I feel very confident to say you're not going to do it for a moderate to severe adult in 4 weeks or in 6 weeks. It's just not enough time. There's the outliers out there that you could see some change, but to really see enough significant change, we go 12 weeks. Even if this person is acute, we're going 12 weeks, okay? We're mapping this out right in the beginning to figure out what the next checkpoint is. After 12 weeks, after we reassess everything, after we see how they progress with the care that we put forward for them, that's when we can really customize and start to dial it in based on the results that they saw in that 12-week period. Now, while that person is acute in the first couple weeks, there's certain things we're not doing with them. We're not going to be taking them through any sort of exercise that causes pain. However, we may be teaching them things like certain certain postural or movement patterns that are important. Someone's got low back issues. Like, for example, I saw a guy a couple weeks ago. He started with us. He works at FedEx. Hurt his low back. Too acute to go through any sort of functional movement correctives in the first couple weeks. But what do we teach him? We teach him breathing, hip hinging, and core stability. We teach him how to get up and sit down from a seated position properly while maintaining a good neutral lumbar spine. We showed him how to bend and lift properly using a hip hinge pattern, more of a deadlift type of pattern versus lumbar flexion. We show him how not to do lumbar flexion and rotation. We show him how to activate, stabilize his core when lifting. And then we teach him certain range of motion activities, things like cat-cow, things like dead bug, bird dog, as long as those things are not painful for him, to start to turn on his brain to activate his core. Okay, and then doing things like manual therapy and taping alongside, of course, our specific chiropractic adjustment. That's how we handle that acute patient. And then this guy in particular, who I'm thinking of, by week 3, he was good enough and pretty much back to more of like a baseline normal dysfunctional, so we could take him through a movement assessment. We do a movement assessment. Now we can gather good, helpful data from there. Then we can build out his functional movement exercise progressions over the remainder of his now 10 weeks of the 12-week plan. Okay? That's how we handle an acute patient with exercise. So certain things are delayed or postponed until they can go through the functional movement component without pain, but there's other exercise-related activities that really need to be taught to someone. Breathing, hip hinge, core, how to bend properly, how to get up out of a seated position properly, so on and so forth. So that's how we handle an acute patient. And the reason that we still follow our systems of engagement and education for those first couple visits, the day 1, 2, 3, and then on day 4, we show them their home care and kind of onboard them to this whole exercise process, even if we're not doing functional movement correctives at that point because they're painful, but we're doing these other things that I spoke of, like breathing, hip hinge, core. That's on day 4. And then day 5, we set goals for them. That whole day 1 through day 5 process still happens regardless, because we found that if we do day 1 and day 2 and the person's acute, and then we just do adjustment only visits and we pause the rest of the system for like a week while they get out of their acute crisis, what happens is that person really loses any excitement about getting their problem fixed, unfortunately, and we find that there's a much, much lower instance of that person now actually committing to a corrective protocol, and unfortunately, now they miss out. They miss out because they're so focused on pain, because we let them only be focused on pain right from the get-go. So I know that maybe sounds a little challenging, because if a person is in a lot of pain, that's their focus, yes. But we found that it's still much more beneficial to the patient in the long run of following the systems, educating them even if they are in pain, okay? Doing things to get them out of pain, but not modifying the tried and tested and proven systematic approach for the first day 1, 2, 3, and then really 4, 5 of our systems. So if you're going to do corrective exercise, functional movement, corrective care in practice, these are the things that we found work the best. Works the best in our clinic, works the best for all these other doctors who we also consult with and help them in their clinics. And so if you want to see more about everything I'm talking about, this is a little tidbit, little piece of the bigger picture. Go to demo.movenowu.com and you can watch a 30-minute pre-recorded demo that I made about a week ago, so it's updated. We also have this 12-week implementation process for chiropractors, so not only do we put this curriculum together, but we have a very systematic way for doctors to implement this and launch this in their practice. All right, perfect timing. I'm at my destination. Hope you have a great weekend, everyone. Great week whenever you're hearing this. And comment questions below. We'll talk soon.